Hello everyone. Today we are going to start a new topic on obstetrics, that is about normal puerperium. So the normal puerperium is defined as the period following childbirth during which the body tissues, especially the pelvic organ, revert back approximately to the pre-pregnant state both anatomically and physiologically. So what this means that it is the period after childbirth during which the all the body tissue, especially the pelvic organ, the pelvic genital organs and all, they revert back to their approximately, not exactly, but approximately to their pre-pregnant state. So this both anatomically as well as physiologically, and this is known as normal puerperium. The puerperium period. And the retrogressive changes are mostly confined to the reproductive organs, with the exception of mammary gland. Uh, which in fact show the period of activity. Mammary gland is more active than the pre-pregnant state. And so the involution, what is involution? The involution is the process whereby the genital organs revert back to approximately to the state as they were before pregnancy. So involution is the state where the genital organ revert back approximately to the state as they were before pregnancy. And the woman is in the puerperium is known as puerpera. Woman is known as puerpera. And the duration of the puerperium begins as soon as the placenta is expelled, and it lasts for approximately 6 weeks, that is 42 days, when the uterus regresses almost to the non-pregnant size. So in 42 days, in 6 weeks, the uterus regresses almost to the non-pregnant size, and the and puerperium lasts till this period. And the period is divided arbitrarily into three different types. The immediate, that is within 24 hours, early up to 7 days, and remote up to 6 weeks. And the similar changes occur also in abortion, but it takes shorter period for involution to complete. And fourth trimester is the time from the delivery until the complete physiological involution and psychological adjustment take place. And according to the ACOG, the puerperium is also known as fourth trimester. And talking about involution of the uterus, first of all, we'll talk about anatomical consideration. The immediately after the delivery, the uterus become firm and retract with alternate hardening and softening. The uterus measures about 20 into 12 into 7.5 centimeter cube, the volume, and the weighs about 100 kilogram, that is 1 kg. And at the end of 6 week, its measurement is almost similar to that of non-pregnant state, and it weighs about 60 gram. And the decrease in size of uterus and cervix has been shown with serial USC or MRI. The placenta site contracts rapidly, and immediately after the delivery, the hemostasis is achieved by arterial wall, smooth muscle contraction, compression, and constriction of vessel by involuting the myometrial fiber, that is also known as living ligature, and other mechanism are formation of thrombus and vessel wall hyalinization. Lower uterine segment. Immediately after the delivery, the lower uterine segment becomes thin and flabby, and it takes few weeks to revert back to the normal shape and size of the isthmus. And the cervix contracts slowly. The external os admits two finger for a few days, but at the end of first week, it narrows down to admit the tip of one finger only. And the contour of the cervix takes a longer time to regain, that is 6 weeks, and the external os never ever reverts back to the nulliparous state. The physiological consideration. The physiological process of involution is most marked in the body of the uterus. The changes occur in the following components like the muscle, blood vessel, and endometrium. In the muscle, there is marked hypertrophy and hyperplasia of the muscle fiber during pregnancy, and the individual muscle fiber enlarges to an extent of 10 times in length and 5 times in breadth. And during puerperium, the number of muscle fiber is not decreased, but there is substantial degree reduction in myometrial cell size. Not in number, but in size. It decreases in size, and the withdrawal of the steroid hormone like estrogen and progesterone may lead to increase in activity of uterine collagenase and release of proteolytic enzymes. And autolysis of protoplasm occur by the proteolytic enzyme with the liberation of peptones which enter the bloodstream, and these are excreted through the kidney as urea and creatinine. The connective tissue which also undergo the same type of degeneration, and the condition which favor involution are efficacy of enzymatic action and relative anoxia induced by effective contraction and relaxation of uterus. The blood vessel. The changes in the blood vessel are pronounced at the placental site. The arteries are constricted by the contraction of its wall and thickening of the intima followed by thrombosis. During the first week, arteries undergo thrombosis, hyalinization, and fibrinoid endarteritis, and veins are obliterated by thrombosis, hyalinization, and endophlebitis, and new blood vessels grow inside the thrombi. The following delivery, the major part of the decidua is cast off. The endometrium is left behind, varies in thickness from 2 to 5 millimeter. The superficial part containing the degenerated decidua, blood cell, and the bits of fetal membrane becomes necrotic, and it is cast off in the lochia. There is infiltration of polymer lymphocyte and over the decidua and the placental site. These act as an antibacterial barrier. The regeneration starts by 7th day. It occurs from the epithelium of the uterine gland, mouth, and interglandular stromal cell. The regeneration of the epithelium is completed by 10th day, and the entire endometrium is restored by the day 16, except at the placental site where it takes about 6 weeks. And for the clinical assessment of involution, the rate of involution of the uterus can be accessed by noting the height of the fundus of the uterus in relation to the pubic symphysis. So the rate of involution of the uterus can be accessed clinically by noting the height of the fundus of the uterus in relation to pubic symphysis. The measurement should be taken carefully at a fixed time every day, preferably by the same observer. The bladder must be emptied beforehand, and preferably the bowel must be emptied beforehand, and the loaded bowel may raise the level of fundus of the uterus. That's why bladder and bowel must be empty. And the uterus is to be centralized with the measuring tape. The fundal height is measured above the pubic symphysis, and the following delivery, the fundus lies within 13.5 centimeter above the pubic symphysis in the first day, and during the first 24 hours the level remains constant. Thereby there is steady decrease in height by 1.25 centimeter, that is 0.5 inch in 24 hours, so that by end of second week the uterus becomes a pelvic organ by the second week. And the rate of involution thereafter slows down until by 6th week, and the uterus becomes almost normal in size. And the involution may be affected adversely, and it is called subinvolution. And sometimes the involution may be continued in women who are lactating, so that the uterus may become smaller in size, and that is known as superinvolution. And the uterus, however, return to normal size if the lactation is withheld in that superinvolution woman. And there is involution of other pelvic structure like vagina. The distensible vagina noted soon after the birth takes a long time, that is 6 to 10 weeks to involute. It regains its tone, but it is never to the virginal state. The rugae partially reappear at 3rd week, but never to the same degree as in pre-pregnant state. The introitus remains permanently larger than the virginal state, and the hymen is lacerated, and it is represented by nodular tracts known as carunculi myrtiformis. And the broad ligament and round ligament require a considerable time to recover from the stretching and laxation. The pelvic floor and the pelvic fascia takes long time to involute from the stretching effect during the parturition. There is a term known as lochia. The lochia, it is the vaginal discharge for the first 2 weeks, that is first 15 days during the puerperium. The discharge originates from the uterine body, cervix, and the vagina. And the order and reaction. The lochia is due to shedding of the decidua and sedua after delivery, and it takes around 15 days. And the order odor of the odor of the Lochia has a peculiar offensive fishy smell, and its reaction is alkaline and tending to become acid toward the lateral end. The color, depending upon the variation of the color of the discharge, it is not known as Lochia rubra, which that occurs in 1 to 4 days. Lochia serosa, the color is yellowish or pinkish in 5 to 9 days, and the Lochia alba in 10 to 15 days, the pale white. Amount the composition of Lochia rubra consists of blood, shreds of fetal membrane, and the residua vernix caseosa, lanugo, and meconium. But Lochia serosa consists of less RBC but more leukocyte, wound exudate, mucus from the cervix, and microorganisms like anaerobic streptococci and staphylococci. The presence of bacteria is not pathognomonic unless associated with clinical sign of sepsis. And the Lochia alba consists of plenty of decidual cell, leukocyte, mucus, cholesterol, crystal, fatty and granular epithelial cell, and microorganism. So what are the content of these three different types of Lochia? In Lochia rubra, it contains blood, the fetal membrane, and the deciduous threads of this, and vernix caseosa, lanugo, meconium, all these things of the fetus. And the Lochia serosa contains less RBC but more leukocyte, wound exudate, mucus of cervix, and microorganism. And the Lochia alba contains of plenty of decidual cell, leukocyte, mucus, cholesterol cell, fatty and granular epithelial cell, and microorganism. And the average amount of discharge for the first 5 to 6 days is estimated to be 250 ml, and the normal duration may extend up to 3 weeks. And the clinical importance is that the character of local discharge gives useful information about abnormal puerperial this state. The vulval pads are to be inspected daily to get information of the order. If there is malodor, if the lochia is malodorous, it indicates infection, and the retained plug or cotton piece inside the vagina should be kept in mind. An amount, the scanty or absent signifies infection or lochiometra, and if the lochia is excessive in amount, it indicates infection. And the color, the persistence of red color even beyond the normal limit, that is more than 4 days, significant sub-involution and or retained beat of conception. And duration, the duration of Lochia alba beyond 3 weeks suggests that it suggests local genital lesion. The talking about general physiological changes in puerperium, the pulse for the few hours after normal delivery, the pulse rate is likely to be raised, which settles down to normal during the second day. And the temperature should not be above 37.2 degree, that is 99 degree Fahrenheit, within the first to 24 hours. There may be slight reactionary rise following delivery by 0.5 degree Fahrenheit, but it comes down to normal within 24 hours. And on third day, there may be slight rise of temperature due to breast engorgement, which should not last for more than 24 hours. However, genitourinary tract infection should be excluded if there is rise in temperature. And urinary tract, the bladder mucosa becomes edematous and hyperemic and often shows the evidence of submucous extravasation of blood. The bladder capacity is increased, and the bladder may be over-distended without any desire to pass urine. So the common urinary problems are over-distension, incomplete emptying, and presence of residual urine. And the urinary stasis is seen in more than 50% of women. The risk of urinary tract infection is therefore very high, and the dilated ureter and renal pelvis return to the normal size within 8 weeks. There is pronounced diuresis on the second and third day of the puerperium, and the only clean catch sample of urine should be collected and sent for examination, and contamination with Lochia should be avoided. The urinary incontinence is a significant problem in postpartum period. GI tract, there might be increased thrust in early puerperium due to loss of blood during labor. in lochia, diuresis, and perspiration. And the constipation is common problem. And the weight loss, in addition to weight loss 5 to 6 kg as a consequence of expulsion of fetus, placenta, liquor, and blood loss, further loss of about 2 kg occurs during puerperium, chiefly caused by diuresis. The weight loss may continue up to 6 months of the delivery. And the urinary tract and renal function, in relation to changes in the pregnancy, the persistence of urinary stasis in the ureter and bladder is observed even up to 12 weeks postpartum. The glomerular filtration returns to normal by 8 weeks of postpartum, and overall increase in diuresis of the expanded water volume occurs in postpartum. The increased GFR in pre-pregnant state returns normal by 8 weeks, and due to the significant physiological adaptation of pregnancy, drug dose need to be readjusted at 4 to 6 weeks postpartum. Fluid loss, there is net fluid loss of at least 2 liters during the first week and additional 1.5 liters during the next 5 weeks. The amount of fluid loss depends on amount retained during pregnancy, dehydration during labor, and blood loss during delivery. The loss of salt and water are larger in women with preeclampsia and eclampsia. The blood values, immediately following delivery, there is slight decrease in blood volume due to blood loss and dehydration. The blood volume returns to non-pregnant level by the second week. The cardiac output rises soon after delivery to about 80% above the pre-labor value, but it slowly returns to the normal within 1 week. The RBC volume and hematocrit values return to the normal by 8 weeks postpartum after the hydramia disappear, and the leukocytosis to extent of 25,000 per mm³ occurs following delivery, probably because in response to the stress of labor. The platelet count decreases soon after the separation of placenta, but secondary elevation occur with increase in platelet adhesiveness between 4 and 10 days. The fibrinogen level remains high up to second week of the puerperium. The hypercoagulable state persists for 48 hours postpartum, and the fibrinolytic activity is enhanced in the first 4 days. The secondary increase in fibrinogen factor 8 and platelet in the first week increases the risk for thrombosis. The increase in fibrinolytic activity after delivery act as protective mechanism. Now talking about ovarian function, the menstruation and ovulation. The onset of first menstrual period following delivery is very variable and dependent upon lactation. If woman does not breastfeed her baby, menstruation returns by 12th week following delivery in 80% of the cases, and mean time for onset of first menstruation is 7 to 9 weeks. In non-lactating mother, the ovulation may occur as early as 4 weeks, and in lactating mother in about 10 weeks after delivery. The duration of an ovulation depends upon the frequency, intensity, and duration of breastfeeding. The physiological basis of an ovulation and amenorrhea is due to elevated level of serum prolactin associated with suckling. In lactating mother, the mechanism of amenorrhea and anovulation are depicted, and we will see that chart. This flowchart shows the mechanism of amenorrhea and anovulation in breastfeeding. What happens is that the women who are exclusively breastfeeding, the contraceptive protection is about 98% up to 6 months of the postpartum. So what happens is that in breastfeeding, due to suckling frequency, intensity, and duration, there is increased serum prolactin level more than 50 nanogram per milliliter. This inhibits the ovarian response to follicle stimulating hormone from pituitary, and there is less follicular growth in ovary. There is due to no follicular growth, there will be low estrogen level, and there will be no menstruation. And also due to high serum prolactin level, it suppresses the release of LH from posterior pituitary, and there is no LH source, and this causes anovulation. Sorry, not posterior pituitary, anterior pituitary. And there is decrease in gonadotropin releasing hormone secretion, and all of this causes no anovulation and no lack of menstruation, amenorrhea. And the increased frequency, intensity, and duration of the suckling is associated with high protein level and prolonged ovarian suppression and lactational amenorrhea. So that's why the lactation provides natural method of contraception. After 6 months, the woman needs contraception even if she is breastfeeding. However, ovulation may precede the first menstrual period in about 1/3, and it is possible for patient to become pregnant before she menstruates following less or confinement. And non-lactating mother should use the contraceptive measure in third postpartum week and the lactating mother in third postpartum month. Finally, talking about thyroid function, the thyroid volume regresses gradually to the pre-pregnant state by 12th week of the time, and the thyroid function returns to normal by 4 week postpartum. Women on thyroid medication should get their thyroid function checked to readjust the drug.